Hello everyone, this is Dr. Govind Rai Garg. In this video, we will discuss the questions and their answers which were asked in pharmacology questions which were asked in INI-CET recently held in May 2022. So recall questions I have got. So we will discuss the questions and their answers. Starting with the first question. Which of the following factor in plasma concentration versus time graph is a measure of extent of drug absorption? So this concept we discussed in our videos also. So what is the concept is, if you see, plot a graph between plasma concentration and time. So we have given a drug, after every half an hour we are measuring the plasma concentration and we plot a graph. Suppose the graph look like this. So what is the points to be noted in this graph? This highest point, if we extrapolate it on x-axis, it is called as Tmax, whereas same point on y-axis is called as Cmax, and the total area covered by this graph, this is known as area under the curve, AUC, area under the curve. So what does these represent? Thus Cmax, first of all, Cmax, it is the maximum plasma concentration. So obviously it will depend upon what dose we are giving. If we have given a dose of 100 milligram, it may be lower. If we give 200 milligram, it will be higher. So Cmax, it will depend upon dose of the drug. What dose you have given, according to that Cmax will change. On the other hand, Tmax, Tmax is the time in which plasma concentration become maximum. So in how much time the concentration has reached to its maximum height, that is called as Tmax. So what does Tmax signify? Tmax tells the time in which concentration become maximum. Means if it become maximum in lesser time, that means the drug is quickly entering the blood. If it take longer time to reach maximum, that means the drug is slowly entering the blood. Yeah? So Tmax, it tells about rate of absorption, how quickly the drug is absorbed. And if we correlate that, the maximum concentration will produce maximum effect. So we can say Tmax tells the rate of onset of action of a drug. If Tmax is quicker, the drug will work quickly. That means we can use in emergency. But if the Tmax is longer, that means the drug will work slowly. Okay. So Tmax tells the rate of drug absorption. So read carefully, rate is told by Tmax. On the other hand, this total area, that means area under the curve, it tells that how much total drug has reached the blood, or we can say it tells about extent of drug absorption. How much total drug has come into blood is told by area under the curve, extent of absorption. And if we compare this area by different routes, like if we compare the area under curve by oral route with the area under curve by IV route, then we can tell about the bioavailability by oral route. So area under the curve helps us in calculating the bioavailability when we compare it with the area under the curve by intravenous route. Okay, so coming back to the question, in plasma concentration versus time graph, which factor tell the extent of drug absorption? Answer is area under the curve. Remember, Tmax tells the rate of drug absorption, Cmax tells the maximum concentration, that means how much dose will produce how much concentration, and half-life, obviously we know in how much time that drug will become half in the blood. Okay, so that is about the first question, easy one, area under the curve is the answer. Okay. Moving to second question, this is a repeat question. Earlier, around 2 years back, this question, exact question was asked, same question, and in our prep ladder videos and in my videos, pharmacology videos, we had given the exact same options, but in different institutes, different other institutes, they had changed the options to match their answer, but the students, they get caught this time because the same options were repeated. Yeah. So first of all, we'll read the question. Manufacturer of a drug company labels the drug contains 500 milligram paracetamol. On quantitative analysis by the authority, it was found to contain 200 milligram. So that means the dose is lesser when it was checked. So according to Drugs and Cosmetics Act, which type of drug it is? Okay. So this is basically a misbranded drug. Misbranded drug. Remember, misbranded means if there is anything wrong on the drug label. Like if they have forgot to write the schedule, like if a drug is schedule H but they have not written, it is a misbranded drug. If they forgot to write IP, BP like things, it is a misbranded drug. If anything is wrong, like the drug label, it is writing 500 milligram, and on the drug tablet inside it is written 200 milligram, it is misbranded. So misbranded is anything wrong on the label of the drug. Okay. Now what is spurious drug? Spurious drug is where the pharmaceutical company, it is mimicking a well reputed company. Like I have opened a new pharmaceutical company and I feel that my products will not be purchased by the people. So what I am doing, which is wrong, is I will make a strip of the drug which will mimic the strip of the Cipla or Ranbaxy or already existing well reputed company. So the name of the drug is quite similar, the strip has same color, everything is same. So I want to make money by misleading the people. So that type drug is known as spurious drug. Okay, and spurious drug sometimes may not contain the active ingredient, maybe lesser. So spurious drug is a totally malpractice. Adulterant drugs, the name says, it contains some adulterants. That means there may be some filthy material, like some from the tablet hair is coming out. So that is, which is unhealthy things. So that is coming out from the drug is adulterant drug. And there is no term like unethical drug. Yeah. So what I was talking about is counterfeit drug. Remember, according to Drug and Cosmetic Act, there is no such word like counterfeit drug. It is used in USA and other countries. Counterfeit drug simply means anything wrong about the drug. Like, so spurious drug also, misbranded also, the other adulterant also, these come under the counterfeit drug. It's a big term in which many other type of drugs are covered. Okay, so answer to this question is misbranded drug. Okay, moving to next question. Which of the following statement is correct regarding this graph? So this is the graph. If you see, it is a graph between the receptor response. That means how much percentage of maximum response we are getting. So we can get maximum 100% response or 80% or 50% or 0% or even lesser. So according to that, we need to identify which types of drug these are. And basically percentage of maximum response means intrinsic activity. So if you remember, it's very easy question. We have 4 types of drugs based on intrinsic activity. We have agonist, we have partial agonist, we have antagonist, and we have inverse agonist. So if you remember, agonist has maximum intrinsic activity, that means 1, or we can say 100%. Partial agonist has intrinsic activity between 0 to 1. That means neither 0 not 1. That means it is less than 100%. It may be 80%, 70%, 60%, anything, but between 0 to 1. Antagonist has intrinsic activity of 0, whereas inverse agonist has intrinsic activity of negative. So now you can see the graph. A has 100%, so it is agonist. B has less than 100%, so it is partial agonist. C, if you see, it is 0, so it is antagonist. And D is in the negative, so it is inverse agonist. It is as easy as that. So now you can see the option A represent agonist, right, but B represent inverse agonist is wrong. Remember, B is partial agonist. C represent agonist, this is wrong because C is antagonist. D is inverse agonist, this is right. A is agonist is right, D is inverse agonist, this is right. So this is the answer. Both of statements are right. B is partial agonist, this is right. C is inverse agonist, wrong. C is antagonist. Okay, so the right answer is C here. A is agonist and D is inverse agonist. Okay, I hope this is an easy question. Moving to next question. Type of stimulatory G protein in PIP2 phospholipase activation pathway. So we discussed in our lectures also, we have 3 types of G proteins, mainly 3 types. One is GS, second is GI, and third is GQ. GS means it will stimulate, S means stimulate, it will stimulate adenylate cyclase enzyme. Adenylate cyclase, when it is stimulated, it will increase cyclic AMP. Okay. Whereas GI says I means inhibit, it inhibits same enzyme, that means adenylate cyclase. When that enzyme is inhibited, there will be decrease in cyclic AMP. On the other hand, GQ, it activate an enzyme, stimulate an enzyme known as phospholipase. Phospholipase breaks phosphoinositol bisphosphate into inositol triphosphate and diacyl glycerol, and these result in increase in calcium, and that will produce the action. Yeah. So simply remember, GS will stimulate cyclic AMP, GI will inhibit cyclic AMP, GQ means calcium, they increase calcium. GQ increase calcium. Okay. So answer here is GQ. And GO sometimes is in very few drugs have this type of protein, it decreases calcium. Okay. So S stimulates cyclic AMP, I inhibit cyclic AMP, Q calcium increase, and O calcium decrease. Okay. Now coming to next question. So here a graph is given between 1 by V and 1 by S. So 1 by reaction velocity and 1 by substrate concentration. First question to me before this question is, what is this graph known as? Yes, this graph is known as Line-Weaver-Burke plot. Line-Weaver-Burke plot. It is a graph between 1 by V, or we can say double reciprocal plot is also seen. Double reciprocal means reciprocal of Vmax and reciprocal of substrate. So it's a graph between 1 by V and 1 by S. So now it is very easy from this graph to identify which type of enzyme inhibition it is. But I will tell you the basic thing. If you see substrate concentration, so substrate concentration tells about Km, whereas V on the y-axis, which is 1 by V, that is telling about the maximum reaction velocity. So if without inhibitor and with inhibitor, the graph is intersecting on y-axis. If they are intersecting on y-axis, that means Vmax will be same. If the Vmax is same, but they are not giving ending at same point on the x-axis, that means Km is different. And do you know which type of inhibition only Km changes, Vmax do not change? Yes, that is competitive inhibition. So in competitive inhibition, Vmax remains same, but Km increases. Okay? So if only it is different on the x-axis, it is competitive inhibition. On the other hand, in non-competitive inhibition, what will happen? In non-competitive, Km is same. Remember, Vmax changes. So if the graph is coming from same point on the x-axis, but it is differently intersecting the y-axis, then it will be non-competitive inhibition. And if both the points are different, then it will be uncompetitive inhibition. Okay. So competitive means the line will be same point at the y-axis. Non-competitive means line will be starting from same point on the x-axis, and uncompetitive means both the intersecting lines are different, x-axis as well as y-axis. Okay, so answer to this question will be, it is having same Vmax but only Km is changing, so it is a competitive inhibition. Okay, moving to next question. A 20-year-old boy was brought to emergency room after consuming some unknown substance. The patient was sweating profusely, saliva was drooling from the mouth, tears were present. Body has involuntary urination and diarrhea. Boy has involuntary urination, diarrhea. So basically cholinergic symptoms are there. On examination, heart rate was 58. So again bradycardia, cholinergic symptom, and BP is again low. So basically it is cholinergic overdose. So which type of poisoning is likely to be? Yes, it is likely to be organophosphate poisoning. And the simple question, what is drug of choice for organophosphate poisoning? The answer is atropine. You all know atropine is drug of choice for organophosphate poisoning. N-acetyl cysteine is antidote for paracetamol poisoning. Naloxone is for opioid poisoning, and physostigmine for atropine poisoning. Okay? So answer to this is very easy. Frequently repeated question on OP poisoning. So answer is atropine. Okay, moving to next question. A patient presents with pre-existing liver disease, consumed a drug and developed worsening of liver dysfunction. That means the drug has worsened the liver dysfunction. Metabolite of the drug responsible is N-acetyl para-amino-benzo-quinone-imine. So that becomes very easy question. So NAPQI is the culprit. So which drug has this culprit? Oh yes, you are all right. Very good. Paracetamol. Paracetamol is metabolized by cytochrome P450 enzymes to this product NAPQI. NAPQI has very high affinity for sulfidal groups. So if produced in large quantities, enough NAPQI will be generated, so it will bind to sulfidal groups, and that can lead to hepatic damage. So hepatic necrosis can occur. So answer is very simple, paracetamol. Okay. Moving to next question, another easy question, which is not the primary treatment agent in rheumatoid arthritis. So we all know in rheumatoid arthritis, the drug of choice is methotrexate. Drug of choice for rheumatoid arthritis in pregnancy is hydroxychloroquine. And another drug very commonly used in rheumatoid arthritis is sulfasalazine. Azathioprine can also be used in rheumatoid arthritis, but it is an immunosuppressant drug and it is not used that commonly. More commonly, the primary drugs are methotrexate and hydroxychloroquine and sulfasalazine. Azathioprine is rarely used, and plus recently biological agents are commonly used. Biological agents like drugs inhibiting TNF alpha, drugs inhibiting interleukin 1 and drugs inhibiting interleukin 6. TNF alpha inhibitors like infliximab, interleukin 1 receptor antagonist like anakinra, and interleukin 6 inhibitor like sarilumab. These are the biological agents useful in rheumatoid arthritis. The answer to this is easy. It is azathioprine, which is an immunosuppressant drug. Okay. Moving to next question. Identify the correct match. So we have to identify correct thing regarding the drug and its adverse drug reaction. So basically, which drug is causing which correct side effect they are asking. So hydralazine, heart failure. Hydralazine is a vasodilator. It is used in treatment of heart failure. It will not cause heart failure. The main side effect of hydralazine is SLE. Remember, it is one of the ship drugs. So hydralazine, sulfonamide, hydralazine, isoniazid, procainamide, they cause SLE. So heart failure it is not causing, rather heart failure is the use of hydralazine. Then verapamil constipation is right. Calcium channel blockers, they will block the calcium channel in the GIT, decrease the GI motility, that can lead to constipation. Aliskiren is a renin inhibitor, and renin pathway we know, renin angiotensin pathway, they secrete aldosterone that will retain sodium and remove potassium. So if we inhibit this pathway, potassium cannot be removed, so potassium will retain. So that will result in hyperkalemia. Aliskiren causing hypokalemia is wrong. Aliskiren will rather cause hyperkalemia. Okay. Atenolol hemolytic anemia. No, atenolol do not cause hemolytic anemia. Which antihypertensive drug cause hemolytic anemia? Yes, it is methyl dopa. Methyl dopa cause hemolytic anemia, not atenolol. So this is also wrong. So the right answer is verapamil and constipation. Okay. Moving to the next question. Regarding the anti-diabetic drug. So which anti-diabetic drug is associated with increased risk of fractures in a female with osteoporosis? So which drugs increase risk of fracture in osteoporosis? So answer to this question is rosiglitazone. Remember, all the glitazones, rosiglitazone, pioglitazone, both of them, they are associated with increased risk of fractures in osteoporosis. Some studies they found that canagliflozin can also increase risk of fractures, but some other studies negate that factor. So it is not 100% sure about canagliflozin, but glitazones, pioglitazone, rosiglitazone are definitely associated with increased risk of fractures. So had it been multiple answer type of questions, I would have gone for both of these, but if we need to choose one, it will be glitazone. Okay, so answer to this is rosiglitazone according to me. Okay, moving to next question. It is a rectification question. Do not try to rectify the half-life of all the drugs. So once it has been asked, just remember that and do not move forward. Okay, just letrozole half-life is nearly 40 hours. So we will answer it is 45 hours. Direct rectification question. So what is letrozole is important. Letrozole is, it is aromatase inhibitor. It is an aromatase inhibitor. And what are the uses of letrozole? Yes, letrozole is used for breast carcinoma, particularly post-menopausal breast carcinoma, and it also is used as ovulation-inducing drug. It is also used as ovulation-inducing drug. Now it is preferred over clomiphene in PCOD. So breast carcinoma and ovulation induction is the main uses of letrozole. Okay. Next question. Which statement or statements regarding use of 5-alpha reductase inhibitors in BPH are correct? So basically they are asking about finasteride like drugs. Remember what finasteride do? It inhibits the conversion of testosterone to dihydrotestosterone. So this is done by 5-alpha reductase and this is inhibited by finasteride. So what is true about finasteride? True. So decrease in serum PSA, that is right. They are decreasing the DHT and that was increasing PSA. So prostate specific antigen, it is a good marker of prostate carcinoma. But when we decrease the testosterone activation, that means the DHT production is reduced, PSA levels are reduced. So it decreases level of PSA. Then increase in PSA is wrong. Decrease in cellular testosterone. Oh, it is wrong. If you see the mechanism, it is inhibiting the conversion of testosterone to DHT. So DHT level will decrease, rather testosterone level may increase. So testosterone level may remain normal or increase, but DHT level will decrease. So decrease in testosterone will not occur. Then decrease in cellular DHT, yes, this will happen because DHT is not produced. So two answers, one decrease in serum PSA and second decrease in cellular DHT. Okay, moving to next question. A 42-year-old chronic alcoholic presents to emergency department with altered sensorium and seizures. He has not consumed alcohol for last 2 days, so likely to be withdrawal symptoms. On investigation, his serum ALT is 150, alanine transaminase is 150, so normal value is around 5 to 40 for most of these enzymes, so it is nearly 3 to 4 times the upper limit. AST is 180, again very high, and gamma glutamine transferase, that means GGT, is also very high. So all these levels are very high, that means the person is having liver damage. So best drug for first line management of this patient. So first of all, for alcohol withdrawal, what we need to do? We have to give some benzodiazepine, some drug which is CNS depressant, because alcohol is a CNS depressant. So to prevent the withdrawal, we have to give a benzodiazepine. The question is which benzodiazepine? Those benzodiazepines which are not metabolized in liver. If they are metabolized in liver, they will not be safe. So which drugs are safe in liver failure? That is the question, and we know these drugs are remembered as stool drugs. So stool drugs are basically short-acting benzodiazepines, short-acting because they do not produce active metabolites. The drugs are temazepam, oxazepam, lorazepam, and astazolam. These are the important drugs which are safe in liver failure. So the answer to this question is lorazepam. All other 3 drugs, they are not safe in liver failure. So lorazepam is the right answer here. Okay. Moving to next question. It is easy question. ACTH is used in treatment of. You know ACTH is used for? It is drug of choice for? Yes, ACTH is drug of choice for infantile spasms. Infantile spasms. And which syndrome these spasms are seen? Yes, it is seen in West syndrome. So ACTH is drug of choice for West syndrome, in which infantile spasms are seen. But if infantile spasms are associated with the tuberous sclerosis, then the drug of choice become vigabatrin. Vigabatrin is drug of choice for infantile spasms in a baby with tuberous sclerosis. Main side effect we all know, it is visual field contraction. Okay. So ACTH answer is West syndrome. Okay. So most other syndromes we use valproate. Next question. A patient of psychosis was being treated with risperidone. So risperidone, we all know it is an atypical antipsychotic drug. He presented to emergency with upward fixed gaze. Upward fixed gaze, it is symbolizing the oculogyric crisis. Oculogyric crisis, or in simple language you can say it is a type of extrapyramidal symptom. So we discussed in our videos that typical drugs have more chances of causing EPS, atypical drugs have less chances of causing EPS. So this will make one more MCQ, that among the atypical drugs, risperidone has highest risk of causing EPS. Yeah? So risperidone has strongest D2 blocking property among the atypical drugs, so highest risk of EPS. So now EPS is present. So what is the treatment? We know extrapyramidal symptom in psychosis, there is imbalancement in dopamine and acetylcholine. So if a drug block dopaminergic receptors, that means there is relatively cholinergic excess. So symptom is occurring due to relative cholinergic excess. So the best treatment will be anticholinergic drug which act in the brain. So we want to decrease cholinergic action in the brain. So central anticholinergic drugs we will use, and the best drug we use is benzohexole, which is drug of choice. Benzohexole is drug of choice for dystonias and oculogyric crisis. If benzoxole is not in the options, then we give first generation antihistaminic drugs like promethazine. Promethazine is very strong anticholinergic drug also. Apart from antihistaminic, it has very strong anticholinergic property. It has very good penetration in the brain. So promethazine is a good alternative to benzohexole. So if benzoxole was in the option, we will mark that. If not, answer will be promethazine. Okay. So EPS, promethazine. Clear? So that is question about risperidone. Moving to next question. A 30-year-old female presented to psychiatry OPD with symptom of hypomania. There is hypomania. The past history of mania is there, and she want to conceive now. Which drug is most teratogenic? So simple question is, which is the most teratogenic drug used in bipolar disorder or mania? So remember, most of the anti-manic drugs or bipolar drugs are teratogenic. Lithium is teratogenic, Carbamazepine is teratogenic, valproate is teratogenic. The olanzapine like drugs are the safest drug, they are least teratogenic, so they are drug of choice for mania in pregnancy. But they are asking which is most teratogenic. All three are teratogenic, but the highest being valproate. Valproate has very high chances of causing neural tube defects, sometimes to the extent of 10 to 15%. On the other hand, lithium can also cause abstinence anomaly, but the risk is much lesser. It is hardly 2 to 3%. So valproate is most teratogenic, we should avoid. If required, we will prefer antipsychotic drugs like olanzapine. But if you want to give, you can give lithium, but we will always avoid valproate. Okay. So that is about the question on mania in pregnancy. Okay. Moving to next question, question 17. Here question is which option is correct regarding increasing order of potency of inhalational anesthetic agent. So we need to arrange the inhalational agent according to their potency. So for that, first we will quickly revise. We know potency is inversely proportional to minimum alveolar concentration, or it's logical. If a drug require more concentration in the alveoli to produce anesthesia, means it is less potent. And we can recall that MAC, which is highest, which drug has highest MAC, which has lowest MAC. Highest MAC is seen with nitrous oxide. It is around 104%. That means even 100% cannot produce anesthesia. Whereas lowest MAC is seen with methoxyfluorine. So that means nitrous oxide will be least potent, methoxyfluorine will be most potent. So first of all, we will see least and most, then we can see the other options. So least potent is nitrous oxide, so it should be at the beginning. So how many options have nitrous oxide in the beginning? Only one. So that will solve our MCQ. Most potent is methoxyfluorine, so it is at the last. Okay. Then in between, obviously the two options remaining, that must be right. So halothane has more potency as compared to isoflurane. So A is the right answer. Okay. So even if you do not know too much, just you know that nitrous oxide is least potent, the answer would have been solved. Okay. Moving to next question. Here they are asking, from the given diagram, identify the mechanism of action of isoniazid. So basically they want to ask the mechanism of action of antitubercular drugs. So isoniazid, first of all, isoniazid is a prodrug. It is metabolized by an enzyme called as catalase peroxidase. This is the bacterial enzyme. It will convert it into active product. And this enzyme is synthesized by a gene known as CAT-G. So CAT-G will activate isoniazid. If there is mutation in CAT-G, isoniazid will not be active, so it will become ineffective. So active isoniazid, it will inhibit the mycolic acid synthesis in mycobacteria, which is the major component of the bacterial cell wall. Okay. So if you see drug A, CAT-G is activating it, and then it inhibits the mycolic acid synthesis. So the answer is simple. It is isoniazid. That means drug A is isoniazid. Now moving to other drugs, drug B is inhibiting the arabinogalactan synthesis, and this is done by a drug called as ethambutol. Ethambutol also inhibits cell wall synthesis, but it acts by inhibiting arabinogalactan. On the other hand, drug C is acting on membrane. Drug C is actually pyrazinamide. Pyrazinamide is inactive. It enters in the bacteria, and inside the bacteria it becomes active, and the active product will act on the membranes. Exact mechanism is not known. Then drug D is inhibiting ATP synthase, and that is done by betacholine. Betacholine inhibit ATP synthase. Then drug E is acting on RNA polymerase, that you all know RNA polymerase inhibitor is rifampicin. And lastly, drug F is working on protein synthesis. So these are the injectable drugs like streptomycin, kanamycin, capreomycin. They inhibit the protein synthesis in mycobacteria. Okay? So these are the mechanisms of anti-tubercular drugs. Okay. Moving to next question. The given diagram shows the steps in formation of bacterial cell wall. Identify the site of action of beta lactams. So we all know beta lactams, they inhibit transpeptidase, or we can say cross-linking. So if you see, first of all, here some UDP is converted to UDP muramic acid. Glucosamine is converted to muramic acid. This is done by phosphomycin. So that means drug A is phosphomycin. Whereas alanine racemase is inhibited by cycloserine. So this is cycloserine. Then transfer outside is inhibited by bacitracin. Bacitracin inhibits the transfer outside the bacterial cell wall. It inhibits a transporter. Then peptide chain elongation. That means enzyme transglycosylase, it is inhibited by vancomycin, whereas cross-linking is inhibited by beta-lactams. Okay, so these are the different mechanisms of cell-wall inhibitors. So answer to this is D here, inhibit the cross-linking of peptide chains. Okay, next question is, a pregnant female with history of lepromatous leprosy presents to OPD with type 2 lepra reaction. What should be the management? First of all, what is the management of lepra reaction? Simple question. In management of reactions, type 1 as well as type 2 lepra reaction, the most important thing is do not stop the treatment of leprosy. So that means multiple drug therapy, 2 or 3 drugs which the person is already taking should be continued, should not change. Plus, we need to give anti-inflammatory agents. Particularly in type 2 lepra reaction, we will give steroids. Steroids are the drug of choice, and do not get confused, they are safe in pregnancy also. So steroids will be the treatment. Thalidomide is used if steroids are not effective, but in pregnancy we will never use thalidomide. So thalidomide cannot be the answer, it is pregnancy. Steroids are given, but important thing is continue MDT also. So the answer will be add corticosteroids. Stop MDT is wrong. Continue MDT and give steroids. Okay, so that is the answer to this question. Next question, active metabolite of cyclophosphamide. We all know cyclophosphamide is an anti-cancer drug. Cyclophosphamide is metabolized to form 4-hydroxy cyclophosphamide, which is a tautomer, that means structural analog of another compound called as aldophosphamide. So aldophosphamide and 4-hydroxy cyclophosphamide, they are isomer, type of isomer known as tautomers. And this aldophosphamide, along with that, it also produces a compound called as acrolein. And this acrolein can cause hemorrhagic cystitis. Okay. So the direct question is, which is active metabolite? Aldophosphamide and 4-hydroxy cyclophosphamide, they are anti-cancer. They are the main active metabolites. The answer is 4-hydroxy cyclophosphamide. Okay. Next question is regarding immune checkpoint inhibitors. First of all, what is the meaning of immune checkpoint inhibitors? Normally, this is a cancer cell. Whenever a cancer cell is produced in the body, our body can take care of that. So these are the T cells. They will attack the cancer cell and kill them. So cancer will not occur. So they will attack the cancer cells and kill them. So that is the normal function of immunity. So this is one immune checkpoint where T cells will not allow the cancer cells to grow. But cancer cells are smart. So what they do, they will attach to the T cell and they will make T cell forget that we are foreign. So now कैंसर सेल ने टी सेल से दोस्ती कर ली, ठीक, तो टी सेल जो है वो दोस्ती के चक्कर में उसको छोड़ देगा. नाउ दिस कैंसर विल कीप ऑन ग्रोइंग. सो हाउ द कैंसर सेल मेक फ्रेंडशिप विद टी सेल? बाय combining with the T cell through some substances. Clear? So these substances may be cytotoxic T leukocyte antigen, CTL, or these may be programmed death ligands. Programmed death ligand which can combine to programmed death receptor. Okay. So whenever a cancer cell can attach to the T cell with the help of programmed death ligands or cytotoxic T cell lymphocyte antigens, then the T cell forget that it is cancer cell. They will keep on assuming that this is a normal cell. So that will result in escape of immunity. So cancer cell will escape immunity and they will keep on growing. Okay. So now we are also smart. We know that कैंसर सेल ने टी सेल से दोस्ती कर ली, तो अगर हम इनकी दोस्ती को तोड़ दें तो टी सेल फिर से कैंसर सेल को मारना शुरू कर दें. Clear? So that is the mechanism of immune checkpoint inhibitors. Basically, we are making the monoclonal antibodies against either PD-1 or programmed death ligands or cytotoxic T lymphocyte antigens. So when we stop this interaction, so T cells now they will start attacking the cancer cell. That is the new concept. Okay. So now which are these drugs which are cytotoxic T lymphocyte antigen against or programmed death against? So against CTLA we have only one drug which is called as ipilimumab. Ipilimumab. It is used in malignant melanoma. malignant melanoma, we use ipilimumab. Remember, it is not multiple myeloma, it is malignant melanoma. Okay. Then we have plenty of drugs now formed, 6-7 drugs against programmed death receptors or ligands. Okay. So these drugs include pembrolizumab, nivolumab, atezolizumab, and semiplimab. These are some of the important drugs which are against programmed death ligands or receptors. Yeah. So these have plenty of uses, like semiplimab is used for squamous cell carcinoma of skin. Atezolizumab is used against urothelial carcinoma. Nivolumab has plenty of uses including urothelial carcinoma, non-small cell carcinoma of lung, and pembrolizumab is having the widest spectrum. It is used against 10-15 cancers including the endometrial carcinoma. Yes, the question here is which is used for advanced endometrial carcinoma. Answer is pembrolizumab. Pembrolizumab. Okay. Pembrolizumab is also used in lung cancer and many other cancers. Okay. Now moving to next question, which is easy one, not an immune checkpoint inhibitor. We just discussed in our previous question that pembrolizumab, atezolizumab, nivolumab all are immune checkpoint inhibitor. On the other hand, cetuximab, we all know cetuximab is monoclonal antibody against epidermal growth factor receptor. It is not against the programmed death receptors. So cetuximab, which is used in colorectal carcinoma and head and neck cancers, it is not an immune checkpoint inhibitor. Okay. Moving to next question, which drug is not indicated in treatment of sickle cell anemia? Now this question you can answer without knowing anything. If you know the nomenclature of the monoclonal antibodies, so bebtelovimab, if you see, it is a monoclonal antibody which is against virus. So it is a monoclonal antibody against virus. Which virus? Which is the virus causing problems since 3 years. Yes, that is COVID-19. So this is a monoclonal antibody against spike protein of coronavirus. So this is used in COVID-19. Whereas other 3 drugs, they are used in sickle cell anemia. They will decrease the risk of veno-occlusive disease in sickle cell anemia. Bebtelovimab, it is used in COVID-19. Okay. One more drug which is used in sickle cell anemia is crenezolizumab. This is a new drug for sickle cell anemia. Okay. So I think this is all. These are the important questions of INI-CET 2022 May exam. So if you have any more queries, you can write in the comments below. Okay. Thank you very much.